number 4, diabetes complications update. So please, I need from the chairpersons to come on the stage. Professor Abdelkhaliq Hamid, Professor Ahmed Taha, Professor Daria Rakhli, Professor Mohammed Nagir, Professor Nader Wadia, Professor Rayaz Malik.
Our first speaker in this session, Professor Luiz Gardete from Portugal. He is the former Vice President of IDF, President of Ernesto Roma Foundation, former President of the AASD Portugal Diabetes Association, Professor Luiz. He will present us diabetes and NAFLD. Please.
Thank you. First of all, I want to say thank you for the invitation to be here in this wonderful conference. My job is to speak a little about NAFLD and the diabetes. It's no more than an update. Where I am from, I came from I come from the Portuguese Diabetes Association. The Portuguese Diabetes Association, it's an institution, it's a non-profit organization which was founded in 1926 by a man, which is in the picture, NAFLD. He was in Boston just after discovering insulin. He came back to Portugal. He found the Portuguese Diabetes Association for poor people, because the poor people don't have money to buy insulin. And he joined people from the trade downtown, and with this money, they give insulin to these kind of people. With the knowledge of diabetes, nowadays, the Portuguese Diabetes Association, it's this picture from old times, the good and old times. The Portuguese Association is a big institute of diabetes. It's an outpatient clinic. We see more or less 18,000 people with 50,000 people with a year, with 3,000 new people. Almost of people are type 2, but type 1 2. This is an integrated clinic, integrated care clinic. It is a challenge to care people with diabetes. So in three buildings, we have all the specialties. Diabetology, pediatric nutrition, ophthalmology, and it's also surgery and dialysis. So the patient, when arrive, you can have three or four consultations the same day. It's good for the patient, give quality, and it's economic, more stable. Well, let's speak a little about NAFLD and diabetes. Well, in the last century, we have a tremendous change of our lifestyle. And with the consequences of this change is the chronic disease. One of the chronic diseases is NAFLD. What is NAFLD? It's one of the most important causes of liver disease worldwide, and will probably emerge as a leading cause of end-stage liver disease in the coming decades. NAFLD is a big umbrella term for a range of liver situations, conditions affecting people who drink little to no alcohol. The main characteristic of NAFLD is too much fat stored in the liver cells associated with insulin resistance. We have another condition, an evolution of NAFLD, the NASH, non-alcoholic steatohepatitis, is a potential severe form of disease and is marked by liver inflammation, which may progress to scarring and irreversible damage, fibrosis, and can go quickly to cirrhosis, carcinoma, and liver failure. Well, NAFLD is a silent condition and certain escalations, and the estimated prevalence, extra burden for development of metabolic conditions, asymptomatic until advanced stage, barriers to diagnosis, and direct markers do not provide a real diagnosis. Because we don't know exactly why people accumulate fat in the liver and others do not. NAFLD is linked to overweight or obesity, insulin resistance, high sugar, high blood sugar, and high liver fats. Several epidemiological studies show that NAFLD is an independent factor for instance, type 2 diabetes, metabolic syndrome, and cardiovascular disease. In persons with NAFLD, screening for diabetes is mandatory by fasting or rather blood glucose or A1C or if available or GGT in high-risk groups. In patients with type 2 diabetes, the presence of NAFLD should be logged for irrespective of liver enzymes, since type 2 patients are at high risk of disease progression. Well, about the prevalence, we have several numbers in the Middle East where we are, where more or less 32% of the people have NAFLD, and the lowest prevalence is in Africa. And in type 2 would be between 40 and 70% of these people with NAFLD. Well, we are in the MENA region. In the MENA region, we have very strong risk factors. Type 2 diabetes, some countries in this region have more than 20% prevalence of diabetes. Obesity, some regions of this, some places of the region are high prevalence of obesity and metabolic syndrome. We have, that depends the place of this region, between 28 and 37. Well, more specific, we have in the Middle East in the recent study from Yanusi and Ahmed, we have in the Middle East 31%, it's more or less 32% I presented the slide before, and in the Middle East, and people with type 2 diabetes with 67% of disease, people have NAFLD. Well, this is a schema about the evolution, could be the main complication of liver disease with progress in non-alcoholic steatohepatitis, in cirrhosis, which is late-stage care, fibrosis, and can go to quickly in some group of people to cirrhosis. What is the fat in our body? 75% is in subcutaneous. We have more or less 10-15% visceral fat, and we have ectopic fat more or less 10-50%. Ectopic fat accumulates in the liver, heart, intestine, and skeletal muscle. So, if you have a positive balance between caloric intake and energy expenditure, there are a buffering of excess of energy in adipose tissue, and the evolution and exhaustion of buffering of capacity in adipose tissue, and this fat goes to the liver, to the heart, to the muscle, and gives metabolic abnormalities. When they are supposed to have more insulin resistance, less mitochondrial function, in the pancreas insulin resistance, type 2 diabetes, in the heart have cardiac insulin resistance, less mitochondrial function, and the liver insulin resistance, high LDL, and less insulin clearance. So, NAFLD is associated with multiple conditions: vascular disease, CVD, malignity, cerebrovascular disease, and type 2 diabetes. There are specific situations of diabetes. Fatty people, usually young people, we have high fructose intake, visceral obesity, they are sedentary, increased CP risk, and they have some genetic predisposition, and these kind of people are between 10 and 20% of this kind of people are young people who drink too much drinks with fructose. Well, how is the criteria to diagnosis? The presence of hepatic steatosis, no significant alcohol consumption, no competing etiologies. And how we can detect and diagnose? With ultrasound, CT, MRI, MRS, or certainly more easy to do the fibroscan. We can use the fat liver index or the NAFLD liver fibrosis score, biomarkers, but they are controversial, and in some times we can do, but in few times, biopsy. NASH detection and diagnosis. NASH has been diagnosed by a liver biopsy, showing steatosis, hepatocyte ballooning, and lobar inflammation. Well, we have easily capacity to see the situation with the fat liver index. It's a very simple algorithm which combines triglycerides, GGT, waist circumference, and BMI. It's a very complex form, but if you go to the internet, you can find this, and very quickly you have the index with more or less approximate situation. Or the same for fibros score, you found this kind of score in the internet, and it's very easy to fill. Well, NAFLD intervention effectiveness. Lifestyle interventions is beneficial for patients with NAFLD, improving not only the liver disease, but also hyperglycemia, atherosclerosis, lipidemia, and blood pressure, reduction of the hepatic steatosis by liver intervention, and in case of risk factor percent intervention, we begin with edit approach, pharmacological drugs. Well, and about weight loss. Lifestyle intervention, being diet and exercise, seem to produce effects in NAFLD and NASH, proportional to the weight loss generated. Pharmacological intervention that produce similar effects seem likewise associated with weight loss, also surgery. Well, there are a lot of nutritional documentation which is very difficult to follow. There are some drugs which efficacy is very low, and they are all off-label. There are drugs in phase 2 trials, which are here, or drugs in phase 3 trials for NASH, and some drugs we have a long expectancy. This from the Gilead first one, they drop out, and we have no more available. There are some trials about semaglutide with those lipids and can improve the situation too. Well, another kind of diagnosis we have is using the fibroscan. Fibroscan is specialized ultrasound for the liver. It measures fibrosis scale and steatosis in the liver. Well, I showed some years ago, we did a very large prevalence study, and we take a sample of 1,000 patients, and we used the fibroscan, and we found in people with type 2 diabetes, 69% of these people have NAFLD, and people without patient after disease, which is the green, we found 28% of the people with NAFLD. We use it in the same study. We compare the fibroscan and the fat liver index, and when we are in steatosis, the two kind of measures of the situation are very similar, the fibroscan or the fat liver I showed before, but if we go to the fibrosis, the score of fibrosis is very low when we compare with the elastography with the fibroscan, which is much better than the index. Well, take-home message. The liver stores excessive nutrients and fat. That is a silent condition, generally a diagnosis, and clinicians tend to undervalue in practice. Type 2 diabetes and FD are reciprocal risk factors and constitute a vicious cycle. Hepatic fat accumulation changes not only liver metabolism but also impact other organs. Lifestyle change, hypocaloric diet and exercise, target NAFLD proportional to weight loss, although effects can be severe. Thank you very much.